السلام عليكم جميعًا، مساء الخير. As per Epson commitment towards supporting CPP patient and their caregiver across the kingdom, it's our pleasure today to kick off the second CPP Expert Forum, the first exposure in Eastern Zone. طبعًا المعروف لا يُعرّف. Allow me to introduce Prof. عبد المعين الآغا as well. He will be the chairperson for today's session, as well as Dr. محمد القحطاني as a keynote speaker. Without further ado, the floor is yours, Dr. عبد المعين.
بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. It's my pleasure to be part of the Epson campaign of increased awareness regarding CPP diagnosis and management. And the campaign started 6 months ago. The first campaign was in Riyadh in June, and this is the second one. And inshallah, in 2024, will try to cover as many cities of the kingdom as possible to increase the awareness of CPP as well as the approach as well as management. We are very thankful to Epson, especially Dr. Munira and Rihad and Nada for their continuous support, for continuous communication with all doctors in order to improve the diagnosis and management of CPP. Today, the program, I'll start with a presentation about overview of puberty, normal and abnormal. Then my friend and my colleague and my brother, Dr. Muhammad Al-Qahtani, will be soon, inshallah, will be a professor, and he's going to talk about CPP clinical case studies and diagnostic challenges of CPP in Saudi Arabia. And finally, we're going to have a discussion to involve our colleagues virtual attending with us, and we'll shed light on the recommendations we got from the first campaign in Riyadh. We'll have some important key points to be discussed. I'll start my presentation about normal and abnormal puberty. As you could see from the slide, we start from the normal puberty about the hypothalamic pituitary gonadal axis. What are the factors influencing the age of puberty? What is the relationship between obesity and puberty? As you know, that obesity in children becomes a global worrisome, especially in Saudi Arabia. We have a lot of children with obesity, and because of obesity, we are starting or we are seeing many cases of early puberty. What are the somatic, sexual, emotional changes for both genders? And we'll shed some light on the exogenous sources of estrogen and the relation of early puberty. As you know, we have two sources of exogenous estrogen. We have phytoestrogen from the plants, and we have xenoestrogen from the plastic and nylons, petrochemicals industry that led to a source of exogenous estrogen and led to early puberty and rapid progression of puberty in children, especially females. And then we'll go to abnormal puberty, and we'll talk about types of precocious puberty, the causes of precocious puberty, central and peripheral, approach to diagnosis, and then GnRH agonists, and we conclude the presentation. Uh, Puberty, as all of you know, that starting from the hypothalamus, and the hypothalamus produce uh, GnRH, GnRH, which is gonadotropin releasing hormone. And the good thing in GnRH, or the important thing GnRH, the secretion from the hypothalamus in pulses, it is not continuous. And that's what we'll explain when we talk about the treatment of central precocious puberty, when we are using DIBO preparation and the release of DIBO preparation of GnRH continuous, that will uh, desensitize and downgrade the receptors of GnRH on the pituitary, and instead of GnRH stimulates the pituitary to release LH and FSH, the medication will suppress the release of LH and FSH. So physiologically pulses, pharmacologically continuous. So when physiological GnRH secrete from the hypothalamus impulses, it stimulates the pituitary to release LH and FSH, and subsequently the gonads in female ovary released estrogen, and in boys testosterone, will lead to secondary sexual character. In parallel to this axis, there is a stimulation of zona reticularis of the adrenal cortex by the ACTH, and zona reticularis is responsible for what is called adrenarche. Adrenarche is the release of adrenal androgens from the cortex, which lead to changes, namely pubic hair, axillary hair, acne, as well as oily skin and oily hair. Both stimulation of gonadarche, and androgens from adrenal gland will stimulate the growth hormone to make a growth spurt, or for growth spurt to happen, the growth hormone need to be enhanced by the androgens from the adrenal cortex, as well as the sex hormones from the gonad. Regarding factors influencing puberty, main factor is genetics, and genetic play about 50 to 80% of variation in pubertal timing. But unfortunately, nowadays, because of a lot of exogenous estrogen around us, as I mentioned, phytoestrogen and xenoestrogen, genetics is not a main factor nowadays. It is the environmental hazards of estrogen and obesity play a major role of timing of puberty. But still, genetic has a role, and the geography, it's being reported that hot countries, their children have earlier puberty than cold countries, and environmental factors, nutritional status, environmental hormonal disruptors, which is in the petrochemicals, industry, plastic, nylon, or phytoestrogen in the plants and in the animals, uh, will lead to early and rapid progression of uh, puberty. Obesity, the relationship of obesity to puberty, because whenever we have more adipose tissue, there is a leptin peptide called leptin released from the adipose tissue, and the leptin stimulates the hypothalamic to produce GnRH. So there is a relation between obesity and puberty by leptin hormone, and that will lead to stimulation of GnRH and then increase pulses of LHFSH, which lead to the early puberty. And this is one of the hazards we have in the environment by the animals having in their food their phytoestrogen, and then we eat the meat contaminated with phytoestrogen, and then our females get earlier puberty than boys, and as well as using of plastics instead of using of fork from metal that will lead to more and more earlier puberty. Changes of puberty in both sexes being described by a Tanner scientist from UK. He classified in female sexual changes as five stages of breast and five stages of uh, pubic hair. In males, five stages of pubic hair and five stages of genital changes. And I'm not sure what's happening. Relax. Uh, Sorry for this. Think. أيوه. So the changes happen whether it is somatic changes or sexual changes or emotional changes happen in female is different than males. Especially the only exception is adrenarche. Adrenarche is a common finding between males and females, but other than this is different. And we have one of the verses in Quran فلما وضعتها قالت ربي إني وضعتها أنثى والله أعلم بما وضعت وليس الذكر كالأنثى. Changes in females completely different than changes in males. Very important, very important tool investigation to assess puberty, whether a normal puberty or precocious puberty or delayed puberty is doing bone age X-ray. And when we do bone age X-ray, it's not important only to see the bone age report. Also, we have to see the epiphysis ourselves, and we have to do calculation, what is called predicted adult height. So, for example, a child started to have early puberty. The bone age, for example, is 9 years, and the child is 7 years of age, so advanced bone age. That is not enough. We have to look into the epiphysis, and we have to calculate predicted adult height and compare it to the target height of the child, calculation of mid-parent height from the father and mother, and compare what will be the predicted adult height in comparison to the target height in order to decide whether the child need to be started on therapy or not. So bone age is not only by report, also we should see it ourselves and we should have all these calculations. Precocious puberty is defined as onset of puberty. In females, first stage of puberty is a breast that is called telarche. I forget to mention in females, telarche followed by adrenarche, and the last step is menarche. Telarche, if it started before age of 8 years, that is considered to be precocious puberty. In boys, the first stage is testicular enlargement when the testicular volume more than 4 mil, and if that happens before age of 9 years, that is considered to be precocious. So, uh, in girls, breasts before age of 8, in boys, testicular enlargement before 9, and in boys, the first stage is testicular enlargement, followed by adrenarche, and the last step, final step for maturation is spermatogenesis, which is usually happened by age of 15s, and in girls, the usual menarche, which is the final step, is between age of 11 to 13 years. So not only we concentrate on the age of development, that is important, but also we have to concentrate on the progression of pubertal sign because we can see a child started to have a female child started to have a breast by age of 8, and then within 6 months, there is a adrenarche, and 6 months later will be a period or menarche. So within 1 year, every changes happen. That is rapid progression of changes. So not only the age, very important, but also the progression of pubertal signs and tenor staging is important to be observed and in order to decide whether we need to stop the rapid progression and we need to stop the onset of puberty or not. And as if all of you know that precocious puberty is 5 times more common in females than in boys. When we come to precocious puberty, either we have a central precocious puberty, and central precocious puberty means that the same physiological process or cascade happened in a normal child, but the age here is early. So early age of a normal cascade started from the hypothalamic pulsatile release of gene RH, then pituitary release LH and FSH, and finally sex hormone release from the ovary and testis. So it is the same cascade happened in normal puberty, but in earlier age. And when we come to central precocious puberty, we have either idiopathic, which is the common in females, estimated to be about 80 to 90% of females getting precocious puberty central idiopathic. While in boys, 70 to 80% of children getting central precocious puberty usually secondary to CNS causes. So central precocious puberty, if it is secondary, should be secondary to CNS causes. Idiopathic, common in females, idiopathic is not common in boys. And when we come to secondary causes of central precocious puberty, the most important cause we have to exclude is hypothalamic hamartoma. Hypothalamic hamartoma should be uh, evaluated by doing brain MRI, not CT scan. So the tool of diagnosis is not CT scan because if we did CT scan in a child with hypothalamic hamartoma, it might not be appeared and we label the child as idiopathic. So MRI is the diagnostic tool of choice. We might have any kind of tumor, astrocytoma, craniopharyngioma, ependymoma, germinoma around the pituitary and hypothalamic region. The child might have a sinus radiation or might have a severe head trauma or meningitis, encephalitis, brain abscess. Mental retardation is one of the causes of central precocious puberty. Hydrocephalus and prolonged hypothyroidism will lead to the secondary CNS uh, precocious puberty. This is an example of hypothalamic hamartoma where you could see the tumor, a big tumor in the hypothalamus. And by the way, hypothalamic hamartoma might be associated with what is called gelastic seizure, bouts of laughing, or bouts of crying. The child might present with the mother, bringing the child with signs of increasing intracranial pressure, precocious puberty, and the mother saying the child is having abnormal bouts of laughing or abnormal bouts of crying. And this is gelastic seizure, one of important association of hypothalamic hamartoma. When we come to peripheral, what is called pseudo-precocious puberty, that means the cascade of hypothalamic pituitary gonad axis was not there. It is starting from the peripheral rather than from central. And when we are talking about peripheral, we might have from adrenal gland, or we might have from the gonad, or we might have from ectopic sources of HCG. HCG is have a common structure with the luteinizing hormone. Human chorionic gonadotropin (HCG) has a structurally similar to luteinizing hormone. That's why it works as luteinizing hormone, but the source of HCG is peripheral from the, for example, teratoma, germinoma, outside or hepatoblastoma outside the CNS. That's why it is a pseudo. Pseudo, any source of sex hormone outside the CNS. That's why the major differentiation between central and peripheral when we evaluate LH and FSH, both basal and stimulated, and peripheral LH, FSH, basal and stimulated will be low, and the central LH and FSH will be high or pubertal range. Of course, in both types, central and peripheral sex hormone will be high. And the main differentiating point as well, apart from LH and FSH, the gonadal size. The gonadal size in the central, whether it's ovary by ultrasound or testis by measuring by orchidometer, the gonad will be pubertal in the central, while the gonad will be small in the peripheral, except if we have ovarian tumor or testicular tumor. So we have two differentiating points between central and peripheral. One of them is laboratory, LHFSH basal and stimulator will be low in peripheral, and gonad will be small in peripheral. McCune-Albright syndrome, always we love it in the MCQ. So whenever we have a postgraduate uh, MCQ, we love macunal bright. It is one of the common causes of peripheral precocious puberty, where we have a combination of cafe au lait macule, we have a precocious puberty, and fibrous dysplasia of the bone. We might have ovarian tumor, we might have testicular tumor, we might have ovarian cyst, all leading to release of estrogen from the ovary or testosterone in macunal bride from the testis. Non-classical congenital dysplasia is also common, especially in Saudi Arabia, because this is autosomal recessive disease. As you know, in Saudi Arabia, a lot of consanguinity. That's why we see a lot of non-classical congenital dysplasia in Saudi Arabia, different from the Western population. We might have a tumor from the adrenal gland, particularly from the zona reticularis tumor that will lead to release of androgens, high amount of androgens, which lead to peripheral precocious puberty. Also, we might have SCG secreting tumor, as I mentioned, from the abdomen teratoma or germinoma or hepatoblastoma, releasing alpha fetoprotein and HCG. Or we might have exogenous source of hormone mentioned about the hazards we are living in, the hazards of phytoestrogen and xenoestrogen. There is a rare autosomal disease happen in children and boys, what is called autosomal dominant, what is called testotoxicosis, where we have activating mutation of LH receptor of the testis, leading to too much production of testosterone without stimulation of LH and FSH, and that is called testotoxicosis. Or we could have a chronic primary untreated hypothyroidism with high TSH. And as of all of you know that TSH, FSH, LH, they have a common alpha subunit similarity. So when we have very high TSH above 100, the alpha subunit of TSH might work on the receptor of LH and FSH, leads to initiation of the cascade of the puberty. We have two diseases in pediatric that lead to autonomous gonadal steroid production. Autonomous means that uh, high production of sex hormone without feedback inhibition to LH and FSH. Uncontrolled. Autonomous means uncontrolled release of estrogen and testosterone. One of them is McCune-Albright syndrome. The other one is familial testosterone. We had a lot of local publications from our colleagues in Saudi Arabia, and we are always honored to have colleagues in Saudi Arabia with multiple publications in all sorts of pediatric endocrinology, reporting that the earlier onset of puberty, age of puberty in Saudi Arabia, especially particularly among females. And that is well noticed maybe because of hot weather, maybe because of obesity in Saudi Arabia, or maybe because of environmental hazards of estrogen. We have plenty of publication. And this in the slides, it's written the reference, anyone who wants to have a look. When we come to evaluation of precocious puberty, always we are as a physician start from history and examination. A history examination is the key actually for the final diagnosis. Without history and examination, we might have a misdiagnosis of a child with precocious puberty, whether it is central or peripheral. And we have to assess the current height of the child. Of course, the child with precocious puberty, initially, the current height will be tall stature and it will be taller than the mid-parental height. A lot of doctors might be misled by a tall child and said why we stop the puberty because the child is tall now, is on 90 percentile. The problem is not now. The problem in the future when the child has an earlier closure of epiphysis, and that will lead to adult short stature in the childhood will be tall stature. So one of the advantages of the therapy with GnRH agonist is to improve predicted adult height or final adult height. We are not looking at the current height because always current height is misleading. Current height always is tall. The child with precocious very tall stature. So we have to calculate the target height and we have to calculate the predicted adult height from the bone age, and we have to observe always the growth velocity of the child, and always we have to see whether the predicted adult height is similar or near to target height or far from the target height in order to decide whether the child need to be treated or not. Bone age is essential, as I mentioned before, is very crucial investigation in any child with precocious puberty, as well as LHFSH basal. And if LHFSH basal is high, pubertal, no need to go to stimulation. But if we have a low LHFSH initially with basal, we have to confirm by doing GnRH stimulation is peripheral rather than a central. Bone age is very important, as I mentioned. And when we come to treatment, GnRH agonists have been the first agonist been in the market since 1981. So far, about 42 years in the market. And this is what we're telling our children, the parents of our children who treating, they are afraid of long-term complication or side effect of GnRH agonist. They are afraid of infertility, or they are afraid of irregular menses, or they think that their girls will never have menstruation because we are using GnRH agonist. And what we assure them, this medication is about 42 years in the market, and for sure, if there is any case of infertility or any problem with menstruation, for sure this medicine was removed from the market. But opposite to that, 42 years and still in the market, and every day another company or another preparation comes to the market means that the safety, long-term safety of GnRH agonist is available. It is the treatment of choice of central. We never treat a peripheral precocious puberty with GnRH agonist. This is a main treatment of central, and sometimes we add to the GnRH agonist growth hormone if we calculated the predicted adult height is far from the target height, is below target height, so we might add growth hormone to GnRH agonist. Uh, the preparation is depot. Depot means it is stored in the muscles and a slow release preparation. And by this slow release preparation, it is continuously available in the circulation, opposite to the natural GnRH, which is pulsatile. So by this mechanism, when it is slow release, continuously available in the circulation, that will lead to down regulation of gene-rich receptor in the pituitary, and with down regulation, we'll have a suppression of LHFSH rather than stimulation. But in the first 6 weeks, till this preparation start to work, we might have some sort of stimulation, and some reported mother will come to you and said, in the first 6 months, the breast of my child is getting bigger, or my child start to have a period, her first period after the injection, and we said this is expected in the first 6 weeks because initially stimulates, but after 6 weeks there will be a down regulation, 6 to 8 weeks down regulation of receptors, and then after that we have to find a suppression of puberty. Now, when we come to the brand variable in Saudi Arabia and the worldwide, in Saudi Arabia we have three brands. Number one is Luprolene, number two is Triptorelin, and number three is Guzerelin. The three preparation, and all of them could be used in precocious puberty. The most or the commonest two is Luprolene and Triptorelin, but sometimes we don't find Luprolene or Triptorelin for any reason. They are out of stock, so we might use Zoladex, which is Guzerelin. When we come to Luprolene and Triptorelin, as you can see in the slide, the dose is different. So the dose for Luprolene 0.3 milligram per kg, while Triptorelin about zero point 0.1 milligram. So 100 microgram is zero point 0.1 milligram. That means the dose of 3 milligram, for example, of decapeptyl or differylene, 3 milligram, of course, decapeptyl comes at 3.75, differylene comes with 3 milligram, is about 7.5 of Librolene. So when you have in your hospital Librolene 7.5 and you want to shift the child to triptolylene, the shifting 7.5 of Librolene equal to 3.75 of triptolene or 3 milligram of triptolene. It's not the same 7.5 and 7.5. The opposite, if you have in the hospital triptolene 3 milligram and it's out of stock and you want to shift your child to Librolene, a 3 milligram of triptolene is not 3.75 of Librolene, it is 7.5 of Librolene. And this is very important to know the shifting from cryptoline to Libroline switching, and this is what we'll discuss in the panel discussion. I have the recommendations we had it the last meeting from our panel discussion in Riyadh. Uh, so we also have in the market, in Saudi Arabia market, what is called extended release gene-rich preparation, gene-rich agonist preparation. Extended release means 3 monthly, and inshallah, soon in the first quarter of 2024, we'll have a 6 monthly gene-rich agonist preparation from Epson. So 3 monthly is available in pediatric use since 2011 for the last 12 years. But in Saudi Arabia, it's been available for at least 3 to 4 years. And my preferred preparation is 11.25 milligram every 3 months to be given to children in order to decrease the pain of the injection and improve the compliance and adherence to the treatment. So 3 monthly is much better than monthly in adherence, not in efficacy. They are both equal in efficacy, but for the adherence and compliance, 3 monthly is better than a monthly preparation. And the studies revealed that there is no difference adult height between girls treated monthly versus 3 monthly triptylene at the dose of 11.25. So as efficacy and side effect, they are almost the same, but for the adherence, of course, when the child has every 3 months injection, much better than to have monthly injection as adherence. And inshallah, we had a promise from the company that we'll have a 6 monthly preparation, 22.5 milligram of triptorelin will be approved soon or be in the market in the first quarter of 2024. In America, there is a preparation called Hysterine. Hysterine, it is like a billet inserted under subcutaneous and it will work for 1 year. 1 year continuous release of GnRH, GnRH agonist, but it's not available in Saudi Arabia. And this is a differylene from Epson. We have 3 milligram, we have 11.25 milligram, and soon, inshallah, we'll have 22.5 milligram. Safety of GnRH agonist, whether from Epson or from other companies, as I mentioned, for the last 42 years, never any reported case of long-term side effect, especially particularly on fertility or menstrual irregularity. But of course, when we suppress the sex hormones, there is a risk of osteoporosis. And for this reason, we have any child started on GnRH agonist, we have to inform the parents that they should have a source of calcium every day, whether it is a milk, yogurt, dairy products, in addition to vitamin D supplementation. Regarding vitamin D supplementation, if the child has a normal vitamin D, we'll give a prophylactic dose of vitamin D. If the child has a low vitamin D, we should have a therapeutic dose of vitamin D. So calcium and vitamin D is important as adjunctive therapy to prevent risk of osteoporosis because of risk of osteoporosis. We have to follow up the GnRH agonist therapy clinically and biochemically 3 to 6 months to the child, as well as bone age every year in order to see the bone age advancement of the growth is stopped and the improvement in the predicted adult height. So we have to follow the child clinically, biochemically, and radiologically during the therapy. So in or I'm not sure this one moves a lot. As a conclusion, see the slide of conclusion. آخر سلايد. لا ارجع. ارجع الله. So therapeutic usage of GnRH agonists for the treatment of children with central precocious puberty has rapidly expanded over the last 20 years. And this is what we are seeing as a physician for the last 20 years. A lot of cases reported all over the world, not only Saudi Arabia, of early and rapid progression of puberty. Sometimes it's not early puberty, but rapid progression. So we have to keep our eyes on both an earlier onset and those who had, for example, the girls had breast by 8, but then other changes happened so quickly rapid. So we have to put our eyes on that. And a lot of reports comes because of environmental induced early puberty and obesity. Various preparation we have in the market and very important for us as a physician. And this is one of the advantages of campaign to inform everybody about various preparation and how to shift or switch from one preparation to another because maybe some of the doctors when they switch from one preparation to another they don't change the dose. They think that all the preparations have the same dose and the same concentration. FDA has approved this 3 monthly injection since 2011, and so far so good, comparing to the monthly in regard to efficacy and safety. And there is no long-term report of fertility issues or menstrual irregularity for the last 42 years from the GnRH agonist. By this, we come to the end of the presentation, and we keep the questions for the end of the panel discussion after the presentation of my colleague, Dr. Muhammad Al-Gahtani. He will talk about the local experience in his center about cases of central precocious puberty, the diagnostic and management approach. Thank you very much.
Slide lesson. طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم بكل خير. بسم الله والحمد لله والصلاة والسلام على رسول الله. I would like really to thank the Epson group for having this important meeting, and it's my pleasure to share with my dear colleague Professor Abdul Ma'in an important topic that hopefully will be so beneficial for the implications. So definitely in the first part, Prof. Ma'in made the things very easy and up to the point from the theoretical point of view and the guidance for the practice. Now let's go and do some clinical cases. I have collected 12 cases in different aspects that will show all the different causes, etiologies, manifestations of the precocious puberties in the pediatric age groups. So the first case, I will take a lot of time because we'll apply all the guidelines mentioned by Professor Abdul Ma'in and the approach of these patients. So let's start. Okay, so case number one, this is a 7-year-old Saudi female child, previously healthy, presented with progressive pubertal signs over the last 8 months. Next question is how to approach a patient. What you will do? So I will answer you. The first thing, as mentioned by Dr. Abdul Ma'in, is the golden rule of the proper history taking and physical examination. Always, always. And pediatric endocrinology is not an exception. For all the medical aspects, history and physical examination is going to give you the diagnosis in more than 80%, by the way. So what are you going to do in the history taking and the physical examinations? And you have to apply all the components of the physical examination: inspection, palpation, percussion, and auscultation whenever applicable, okay? So for this patient, what are the important questions that you will ask in the history? Dr. Fadil, can you help us?
There is any advancement of height, this causes the consequences of secondary sexual character. May this help to differentiate between
Excellent. So if you made it as an approach that you will tackle the things is much better than asking about certain points. So let's apply it here. For example, first, is it really precocious puberty or not? It might not be precocious puberty. So it might be a lump. It might be an abscess in the breast. So be careful. This is number one. Number two, is it progressive or slow? Because this will make the whole story different. And that's why, Prof. Abdul Muin mentioned those patients who are having slow progression, you might not even interfere, just observe and follow. Number two, is it central, precocious puberty, or peripheral? So this will help you in the questions. So you'll ask, what are the symptoms and signs these patients might have from the central precocious puberty versus the peripheral precocious puberty? So what, can you give us some questions, Dr. Fadel?
To differentiate between central and peripheral, if there is any adrenarche, associated adrenarche, consequences of development of...
What is the single most important question?
To differentiate between central and peripheral,
yes.
there is thelarche.
Yes, exactly.
Breast
so
development.
breast. Was it started with breast or not? This is the most important. So this will differentiate for you the central precocious puberty from the peripheral. And then symptoms and signs of increased intracranial pressure. Don't forget, especially with boys, the major cause of central precocious puberty is mainly related to the CNS, whether it is tumors, whether it is genetic defect or midline defects, or even acquired like trauma, meningitis, etc. And then etiology symptoms. So ask about symptoms that might give you a help in the symptoms. For example, if the patient is exposed to these plastics, the environmental factors that might trigger the precocious or not. Or if the patient had a severe trauma with loss of consciousness, this patient might have developed later on a precocious puberty, or a patient with severe meningitis with complications, etc. So then complication symptoms. Is the patient is having prone to have any serious complications? This is very important. You have to ask. So if you divide your approach to the groups instead of points, this will help you a lot. Okay? And then don't forget the genetic potential of the puberty and the family history, because the first question will ask the parents, the mother and the maternal aunts, and from the paternal aunts as well, what age they got their puberty, because this patient might be on the same genetic potential. So it might be in need for the intervention. Okay, so what to examine for? Very important, make your approach general, so not to miss. This is very important. So you will do the vital signs. Vital signs are going to help you or not? Dr. Fadel?
Yes.
Yeah, how is it going to help you? Give me two examples.
There is in the case of any classic form of congenital adrenal hyperplasia or rare form CAH, they may be present with hypertension.
Excellent. So this is very important. So the vital signs are so helpful for me, either tachycardia, bradycardia, or the blood pressure, which is the major component here, is going to help me. Growth parameters plotted in the proper chart with the oxylogical measurements and the mid-parental height. This is very important, and we'll apply it now. So for example, hypertension, tachycardia, if the patient is short or tall, if the patient is proportionate or disproportionate, and then the limb proportions, very important. These are the oxylogical that will help you. Clinical signs of puberty, and you have to do the Tanner staging exactly as it is mentioned in the 4 or 5 stages of Tanner staging. Clinical signs of etiology, for example, if the patient is having hyperpigmentation in the skin, this will help you. If the patient is having caveolus spots, this will help you. If the patient is having dysmorphic features, this is going to help you. And then the clinical signs of complication of the underlying problem. This will help too. Very good. So these are some of the oxylogical. You have to do the sitting height, so you can make the upper to lower segment ratio. Is the patient proportionate or disproportionate? If it is disproportionate, is it upper segment or lower segment defect? And then look for the limbs. This is very important. Is the patient normal, rhizomelic, mesomelic, or severe micromelic, or only acromelic? So these are going to help you to differentiate if the patient is having syndrome. The second most important is the midline defects. Look please for the midline defect. This will help you. Why, Dr. Fadel, you think the midline are important? Because the pituitary is midline structure. Hypothalamus is a midline structure. Septum pellucidum is midline structure. So anything that affects all of these, or even tumors, anatomical defects affecting this midline, this definitely is going to affect the patients and might be a clue for the precocious puberty. Very good. So this is our patient. You can see this is in the Saudi growth chart. What is the most prominent here is that the patient was growing very rapidly over the last 1 year. So she jumped a lot, and the final current height now is much, much higher than the mid-parental height. So this will give you a clue. And unfortunately, sometimes this jump of height might be, the parents might get happy of that, which is not good at all. So always we warn the parents, compared to the short stature might be benign, but tall stature is almost always not a benign thing. Either it's a precocious puberty, idiopathic in the females, or it's a malignant or tumor or structural anomaly in the brain that these patients should be taken care of. Okay. Fadal. Yes. Definitely. Yes.
Yeah. He cross or she, the patient cross 2 or 3 major percentile within a normal period, within a short period, of time. That's been alarming. There's something wrong. Then he will end as Prof. Raga in short stature. So, yeah.
So I always tell the parents, this is your final height, which you get it early, and that's it. You will be done early. This is a problem. Okay, so this is one of the indications for the treatment, of course. The other thing is this patient and our patients, when we applied all of these, their patient was having normal for age vital signs. It's not stable. Be careful. Stable means there is no heart rate. So no dysmorphic features, proportionate tall stature for age, sex, and mid-parental height. There was no signs of increased intracranial pressure. Neurocutaneous manifestation was not there. Breast tenor stage was 3, pubic hair stage 1. So what do you think? Is this central or peripheral? Dr. Fadel, what do you think from this examination? It's clear because the tenor stage and this patient started with the breast budding, so definitely this patient is having central. Okay, so how to investigate these patients? Again, biological progression. This is very important, as mentioned earlier. Bone age is going to help you. What patient, biological age this patient is progressing to compared to the chronological age. So these patients almost always, they are advanced. So bone age is going to help you. Very important, and it is the first investigation that will help you. Am I going to interfere? Am I going to observe? Is dependent on the bone age. And then you have to do the basic and the dynamic hormonal profile for the hypothalamic pituitary gonadal axis. And to make it very easy for you, either there is a pathology in the hypothalamus, there is a pathology in the pituitary, or there is a problem in the gonads, or their secretions, or their functions. And of course, the receptors, whether here or there. But the first two are the central, and the last one is the peripheral. But the end product is going to affect all of these. Ultrasonography. This is very important information. You know what is the first clinical sign of puberty in males? Fadel.
Yes, testicular enlargement.
Okay, what is the actual first pubertal sign in females?
Increase ovarian size.
Excellent. So that's why, because it's not applicable clinically, but when you do ultrasound, you will see the difference, and this will help you a lot for comparing the gonadal size compared to the patient's peers. Indicated blood tests. So there is nothing called routine tests. Always you have to have an indication. I will do thyroid function test because of. I will do CBC looking for. So always make things clear in the blood test. Of course, we'll do the hormonal profile and then the stimulations. Further radiological investigation will depend on your findings out of these cases. Okay, so these are the results. The bone age. This is the bone age of 7 years, which she should be. And this is the actual bone age for her. It's 12 years. So it's advanced almost 5 years. Her basal LH was 0.1 and FSH 1.3. If this basal was high, no need to go for the stimulation. For example, if the patient is having 0.6 or more, I mean, you will find it 2, 3, 4. So this patient is having the central precocious puberty, and no need to go for the, especially if you have the very high sensitive, ultra-sensitive assays, that will help you to detect very minute levels of LH and FSH. And we know the FSH component here is not really helpful for neither the diagnosis nor the management. However, the ratio will help you in the investigations. The estrogen level, sometimes it might be helpful, but with the assays, it might not help you. So still depend on the LH and mainly LH level. The pelvic ultrasound showed in this patient ovary size of 1.6. So the estrogen level of 8 is not yet conclusive. How about the ovarian size is 1.6, which is very large for her age. So what is the next step?
We need stimulation.
Okay, so you have to stimulate.
stimulation.
Very good. Either you'll do the GnRH or GnRH analog stimulation test. When we use the stimulations, the standard one is the gonadorelin, but unfortunately it's not available. I've asked even in King Faisal, it's not there. This is being used as an IV, and they will do the measurements every 30 minutes for 2 hours, and then the next day level. Triptorelin acetate or liprolide acetate, both of them, the aqueous solution, the subcutaneous preparation is the best one to do as alternative. And here you can do the LH-FSH at 0 time and then 3 hours. If the level above 4, this is diagnostic of the central precocious puberty. The 24 hours actually is going to help you only for the gonads functions. So it's not much of help in diagnosing patient with central or peripheral. Okay, our patient, the LH was 7.6, so definitely this patient is having...
Central precocious.
Okay, what is the next appropriate step?
MRI.
MRI. Although in females, more than 80% is, up to 90% is idiopathic, yet if the patient is proven having central precocious puberty, it is indicated to do the MRI if available. Otherwise, go to your history and physical examination. If it is indicated, you have to. If not, okay, so you can observe the child, okay? For females, not for males. Okay, so this patient, we did the MRI. You have to ask specifically, I need hypothalamic pituitary anatomy with the contrast. And this is the film, and it's showing the normal anatomy. So this is the stalk, and this is the anterior, the posterior. This is the bright spot of the posterior pituitary gland. So the anatomy is well and normal in this patient. So the final diagnosis is idiopathic central precocious puberty in females. Okay. What is the proper treatment? Proper treatment in these patients, as mentioned clearly, is with the analog. And the analog is going to suppress the secretion of the genuine pituitary hormones through under-regulation of the receptors. So the receptors will go down regulations after a while of the treatment. The preferable one we use actually in our practice is the diferilin. Diferilin is very effective. We use it and try to use it before the 90 days, so 85 to 90 days. As an IM injection, this is cost effective. This is very effective as a treatment, and the adherence is 100% almost. Duration of the treatment is individualized, so it's case-based. Sometimes we might use it only for 1 year, and some patients we might use it for 2 or 3 years. What is the treatment? Is to have a good response in preventing the pubertal signs and bone age progression and emotional stabilization. This is very important, because these patients, the major problem of them is having this rapid and change in the personality and the self-esteem, which might affect this patient behavior, school performance, and the social interactions. And this is the diferoline. This is the usual. This is the available one in Saudi, and inshallah soon. We just know that it's going to be available inshallah next year. The 6 monthly IM injection. Okay, after 1 year follow-up for this patient, this is her bone age, so it is almost stable at 12 years. So this is a good achievement. Number two, you can see now the growth pattern is not anymore of progression. It's more of static almost. So this is a good achievement of having the effective treatment. Okay. Okay. So improved emotional well-being of that patient. The bone age is suppressed and the LH is suppressed immediately after starting the treatment. Okay. The other cases will go over some of the causes mentioned. So in this patient, this is an 80-year-old male presented to my clinic maybe 4 or 5 years back. The father told me, you know, my child is having only very little axillary hair, and that's it, which is very easy and very simple reason. You know, I was doubt to come to you. When I saw the patient, he was 8 years. He has a mustache. He is tall person. When I examined his genitalia, it is stage 4 and 5. So I was really surprised. And when I told the father, he wasn't expecting this problem. I sent him immediately to MRI. And unfortunately, he was having this brain tumor, which is GnRH secreting hamartoma. And patient went to the surgical procedures and went to the King Faisal, and unfortunately I didn't see him after that. Okay, so this is another one child with the, this patient is having the tumor, which is the astrocytoma mentioned by Prof. Moin. So astrocytoma is another tumor, malignant tumor that might have these patients presenting with precocious puberty. Immediate referral to pediatric neurology. You might use the diferoline even after the surgical procedures. They will show good response. The third case is a 5-year-old male with progressive pubertal signs over 6 months. Clinically, testicles tenor 3, pubic hair stage 2. Very important. Prepubertal LH and FSH and high HCG and high testosterone. أنا أعطيتكم diagnosis. Huh? So this is the germinal cell, mostly the pineal gland brain. So these tumors, the patients will have the what's called the GnRH independent. So, but still, although it is from the brain, it is not GnRH dependent. Be careful, because here it's HCG dependent, and HCG will do almost even, if not more, than the LH function on the gonads. Case number 4, a 5-year-old male with gelastic seizure. So this patient is known case of gelastic seizure. So presented with progressive precocious pubertal signs. So this patient did not come immediately to you because he was following with the neurology. But this patient, once the mother noticed the precocious puberty, she came to you. This patient having pubertal LH and FSH and testosterone. So this is definitely as a central. So this is hypothalamic hamartoma near the mammillary bodies. Very important. And this is specific for this type of the tumors. They are almost in the midline. Okay, number 5. 5 years and 5 months old female with progressive pubertal signs. The breast tenor stage 2 and the pubic hair stage 1. Pubertal levels of LH, FSH, and estradiol. So, central. So is this going to help you? This is general examination. So how is this going to help you, Dr. Fadel?
This caveolate spot,
okay,
with this early onset of central precocious puberty, we should think about neurofibromatosis.
Type?
Fit the criteria. Type 1.
Type 1, excellent. So always, as we mentioned before, history and physical examination, inspection, once you inspect the patient as a whole. Don't forget the back. You might find these lesions only in the back, and nobody will ask you. I remember one patient having such lesions, and the father's trying to hide them, not to see them. And he's telling me, you know, my daughter is short. I've tried to ask him to examine the patient, he refused. And definitely the father was having the same disease. Okay, so the diagnosis is neurofibromatosis type 1, optic nerve glioma. So these patients, specifically, they have gliomas. So now we have hamartomas, we have the HCG producing gliomas, and we have now the optic nerve glioma. Okay, so this patient is a 4-year-old referred for circumcision. The surgeon found him hypotonic, so they called the neurologist. Neurologist observed the child to be short, and they called the pediatric endocrinologist. When I came, I was shocked because this patient is cretin. This is unfortunately missed case of congenital hypothyroidism born in Saudi Arabia. So he was born in Al-Hassa, and unfortunately he was missed from the neonatal screening. His TSH was 970 something. Okay, excuse me, help me. Okay. وقف ترى، حاول تمشي الله فيك. آسف. لا سلايد كيس 4 الظاهر او كيس 5. كيس 4. Okay, I think this is the one. No. Okay. هو ما نقدر نحرك بالماوس الثاني لأن هذا شوية، هذا صار ما هو. أوكي، شايف صاير يرجع هذا. أوكي سوري، إن شاء الله يزبط. Okay, so this is the child, and the patient was having severe. لا there's a problem here I think. اي لو تسويها لي انت الله يعافيك احسن. Okay. Very good. Move please. Bad. Okay. So the likely diagnosis here, because the patient is dysmorphic, again, history and physical examination. If the patient is dysmorphic, ask yourself, what could be this problem? Is it a syndromic? Is it something acquired? Is it metabolic? Is it endocrine or non-endocrine? And then try to match it. So this patient is having cretin. So this patient is definitely by clinical is cretin. His initial TSH was 970. He was treated, but 1 year later, he developed progressive through pubertal signs, testicular tenor 3 and pubic stage 1. What type of puberty is here? Central or peripheral? Central. What is the cause?
High TSH, because alpha subunit of TSH.
It's not alpha, it's the beta.
Beta subunit.
Because alpha is common between LH, FSH, and TSH. Beta is different between LH and FSH, but between LH and the TSH, it's almost similar. Once it is getting high, it will go to the receptor of the LH and stimulate it and will cause the precocious puberty. Next, please. Okay, so this patient, 22-month-old toddler, has a progressive benign enlargement. Clinically, he was having normal blood pressure. His height at the 97th centile, benign length is 7.5 centimeters, prepubertal testicle, prepubertal, pubic hair stage 2. So prepubertal LH-FSH, undetectable HCG, and very high testosterone. See the difference between this patient and the other one with the HCG. with the central one. With the central one, the HCG was high in this patient, undetectable HCG. So, okay, Dr. Fadel, what do you think the diagnosis here?
Just to toxicology.
Okay, why? So because this patient is not having a central, this is autonomous production of the LH on the gonadal receptors.
But in those patients, that testicular size usually they are normal or
Yes, they should be normal.
normal.
Initially, they should be normal. But be careful, all the peripheral cases, if they are not treated well, they might end like congenital adrenal hyperplasia. If not treated well, they might convert. With the exposure to high androgens, they will convert to central. Okay? Okay, this is number 8. So what do you think this patient is having? 3-year-old female, recently diagnosed with hyperthyroidism. What is the most likely diagnosis?
And as seen in the picture, there is a cafe LH spot.
What is the specific about this cafe spot? It's not cafe spot. It's
unilateral.
Number one.
Not cross midline.
Number 1, number 2, number 3. The border is clear or not clear? The border here is not clear. So it's not cut. Okay? Like the other, if you remember the neurofibromatosis, their cut is clear. They call it coast of California. And this is the coast of Maine. The coast is not clear or not a straight line. So these having another, this is the similar to the male cystotoxicosis, but in the females. But they might have it even in males. So the ovary is full of cysts. And these patients, of course, having the third component, which is the fibrous cystica. Next, please. Okay, this is case number 9. No, next, please. Okay, so this is an 11-year-old male with progressive pubertal signs over 1 year. Testicle tenor 3, pubic hair tenor 2, the bone age is 14 years. Okay, pubertal levels of LH, FSH, and testosterone. So, central or peripheral?
Central.
Central. So what shall you think of? This is a male. And by the way, in this pathology, it might be both in male and female. And this is, again, this is another problem of the midline defects. But this is causing supracellular cyst. So supracellular cyst or arachnoid cyst might cause compression and activation of the hypothalamus to produce more of GnRH. Next, please. Okay, so this is a 4-year-old male for the first-degree cousin. Again, the family history, very important. Consanguinity is very important. Presented with the advanced pubertal signs. Clinically, very tall, tenor testicular 1, pubic hair stage 3, bone age is 8, LH, FSH, prepubertal, testosterone very high. What do you think?
This is not a classic form of CAH.
Yeah, so what is it, central or peripheral to start with?
Peripheral.
So this is peripheral, definitely. That's why, the most important is testicular stage 1, okay? And he, compared to his peer of the same age, he's very, very tall. His youngest brother was diagnosed by the neonatal screening, so he didn't have these complications. Next, please. So this is non-salt wasting. Okay, so, and this is his growth chart initially. Okay, next, please. Okay, this is a very interesting case. So this patient, مشي شوي لافي. Okay, so this is a 20-month-old female presented with progressive severe acne, linear overgrowth, and pubic hair. Clinically, she was irritable in examination. She was hypertensive. Breast tenor 1, pubic hair tenor 2. So LHFSH, prepubertal, high testosterone, and high estrogen. What do you think this patient is having? Central or peripheral to start with?
Peripheral.
Peripheral, excellent. Why?
Because the prepubertal HFSH.
Number 1, before that?
Yes, or breast tenor stage 1.
Excellent. So why does she have this high testosterone? What do you think of?
Most likely adrenal source.
Excellent.
With congenital adrenal hyperplasia.
Okay.
Could be the cause, or adrenal tumor.
Because this is rapid progression. See the severe progression of this patient? So the diagnosis of this patient was having adrenal carcinoma. Okay, and this is after 6 months of the surgical resection. You cannot tell this is the same patient. Next, please. I think the last case. So an 8-month-old girl. I had 2 cases, unfortunately, for the last maybe 10 months. Progressive breast budding, pubic hair growth, and vaginal bleed. Okay, clinically has normal blood pressure, length in the 19th centile, breast bilateral tenor stage 2, pubic hair stage 2, and the pubertal basal LH, FSH, and estradiol. The peak stimulated LH and FSH levels were 65.9 and LH and FSH of 12. What do you think this patient is having?
Central precocious puberty.
Okay, so this is idiopathic, is it? We didn't say that the females having idiopathic precocious puberty, if it is central, in more than 90%. Is that true? Well, this is an exception because see the age, 8 months. Be careful about the infants. Whenever you have an infant with the precocious puberty signs, it is brain anomaly or brain tumor till proven otherwise. Show me, please, the slide. Okay, so this is hair MRI. This is the T1 weighted sagittal image obtained of the diagnosis showing the hypothalamic hamartoma. So hypothalamic hamartoma, yes, it is the commonest in all over, but if it is an infant, the females are more prone to have this type of the pathology. Thank you very much.
Thank you very much, Dr. Muhammad. Very, very interesting cases, and this is a review of most of the causes of precocious puberty as practical, is not theoretical. All these cases has come to the clinic of the endocrinology clinic of Dr. Muhammad and his colleague. So by this we had covered theoretical and practical aspect of the precocious, central precocious puberty. And now we just shed some light on the important practical points of various preparation of GnRH agonists available in Saudi Arabia. We have many preparation, and this is the consensus we had in the first meeting in Riyadh 6 months ago with our expert doctors. Can we have the slide? Okay. So can we make it a little bit bigger? Can we make it the whole screen? الشاشة كلها خلي الشاشة كلها. Okay. So availability of GnRH agonist preparation in Saudi Arabia, as we mentioned, we have many companies. We have 3 companies. One is Librolin, the other one is Triptorelin, and the third company is Zoladex. The most 2 common is Triptorelin versus Librolin or Librolide. Triptorelin comes into so far into 2 preparation, and inshallah soon we'll have 3 preparation. We have monthly or 4 weekly. By the way, when we say monthly, it should be 28 days. The month is not 30 days. The month means 28 days. And when we say 3 monthly, it's not 90 days. It should be 84 days. So when we multiply 28 by 3, that is 84 days. So the month in the 6 hormones means 28 days, not 30 days. So monthly preparation of triptorelin, 3 milligram by the Epson. And there is another preparation called decapeptyl 3.75. Whether triptorelin 3 milligram or 375, both of them equal, should be used in monthly preparation. 3 monthly preparation is 11.25 milligram, and 6 monthly preparation is coming soon in the market, will be 22.5 milligram. When we come to another brand in Saudi Arabia, which is Librolide, and the Librolide comes in two preparation, comes in 7.5 milligram, and 7.5 milligram of Librolide equal to triptorelin 3 milligram. This is very important for all physician treating with GnRH agonists. 3 milligram of triptorelin or 3.75 of triptorelin equal to 7.5 of Librolide. Is not equal to 3.75 of Librolide. It's not 1-to-1 ratio. And this is very important. So 7.5 milligram Librolide equal to triptorelin 3.75 or 3 milligram. And 22.5 milligram of Librolide 3 monthly equal to 11.25 milligram of triptorelin 3 monthly. This is very important because a lot of confusion between different hospital, especially when the patient moves from one hospital to another. For example, the patient was treated in one of the governmental hospital in Abha, for example. He was on Librolin 7.5 and comes to Jeddah, where we have in the University Hospital triptorelin. So 7.5 milligram of Librolin equal to 3 milligram of triptorelin and vice versa. This is very important message for everyone. Other slide, please. Okay. And what's Saudi FDA recommendation in the pamphlet regarding the doses? This is also another issue of confusion between doctors. So, if we have triptorelin 3 milligram, which is the same as decapeptyl, differelin 3 milligram, equal to decapeptyl 3.75 milligram, which are both of them triptorelin. If we have a child, the weight of the child is less than 20 kilogram, so the child should receive only half of the volume of reconstituted suspension of the injection, half. If the weight less than 20, should receive half. If the weight between 20 and 30, should receive 2/3 of the volume of reconstituted suspension. And if the weight is more than 30, should have the full volume of the injection every 4 weeks. Again, weight less than 20, half. Weight between 20 and 30, 2/3. Weight more than 30, full injection every 4 weeks. If we have the preparation of 11.25 milligram, if the weight is more than 30 kilogram, the patient should receive full dose of 11.25. If the weight of the child between 20 and 30, should receive 2/3. If the weight of the child less than 20, should receive half of the dose. This is very important. So these two slides, please, practically important, because I found a lot of confusion between doctors regarding switching from Librolin to decapeptyl, and regarding the Saudi FDA recommendation of the dose of triptorelin. Next slide. So the final recommendation of our expert panel that we need in Saudi Arabia to have a good understanding and interpretation of biochemical markers among pediatric endocrinologists for a critical role. We have to have the standard of care for children. We have to have a unified consensus of treating children with central precocious puberty, as well as to have the registry of the central precocious puberty among Saudi Arabia. And this is one of the, inshallah, coming objective for Epson to have, inshallah, after at least 1 year campaign, to have a consensus and to start to have registry of cases of central precocious puberty. Next slide. And the doses, as I have mentioned in the previous slide, of triptorelin versus leprolin. By this, we come to the end of the campaign. And before that, if we have any questions from those attending with us or online, we'll discuss it so far. This is question. We know that in girls the most common cause is idiopathic. When you recommend to do brain MRI in girl with central precocious puberty. So this is one of the good questions. It is one of the debatable question about MRI and central precocious puberty. It's been mentioned in my presentation, as well as Dr. Muhammad, my colleague Dr. Muhammad, the presentation, that because in girls, majority of cases is idiopathic, there is a debate regarding whether or not to do a brain MRI to every girl with central precocious of puberty, and another debate if we are going to do it at what is the cut off age you'll do it or not. In my practice and by my review, most of literature, they said if a girl less than 6 years of age, less than 6 years of age with central precocious puberty, we have to do it. We have to do it even if she doesn't have CNS manifestation below age of 6. Between age 6 and 8, this is a gray zone of precocious puberty, because as you are aware, in certain countries of the world, they need to classify the definition of central precocious puberty as less than 6 years in girls rather than 8 years. So 6 to 8 considered to be a gray zone. So between 6 and 8 depends on the clinical manifestation of the child, whether we have symptoms of CNS manifestation of brain tumor. So the consensus said less than 6 years in girls you do it. Between 6 to 8 depends on clinical. But in boys, any case of central precocious puberty at any age, we have to do MRI brain, because the majority of cases of central precocious puberty in boys is secondary to CNS causes. This is the answer of the question. Any other questions? Okay, this question, Dr. Muhammad will answer it. Would you, Dr. Muhammad, consider if the patient present only with body odor? Uh, and now, mashallah, the mothers in our community in Saudi Arabia, they become very educated. Yeah, I am very surprised about high level of education among mothers, and they come to your clinic, even in your private clinic, they are paying the money for consultation just because their child start to have a change of body odor with no other signs of precocious puberty. So, uh, would you consider it a sign of precocious puberty? Would you consider it for any investigation workup, or you are going to observe for further manifestation of precocious puberty?
Thank you, Prof. Of course, we know the three common features between the males and the females as secondary sexual features are the axillary hair, pubic hair, and the body odor. So you should ask also, out of even if the patient is having a breast, or you should ask about the body odor as one of the clinical sign of the adrenal source of adrenarche. So if it is isolated, if it is isolated only, I should take more history to make sure that the other important central precocious pubertal signs are not there. This is number one. Number two, I have to document it by examination. And then if I documented that the patient doesn't fit at all, the symptoms, you might consider it as isolated or part of pseudo-precocious puberty, and the observation is the best management in this patient, and to tell the mother what to observe, when to come, and what to do.
Thank you very much. The third question, would you consider family concerned that girl is not ready for menses and treatment gene rich agonist, even no central precocious puberty? So this is the questions about psychological impact of puberty. And this is what we see in the practice. And the doctor asked this question is an excellent question because, you know, sometimes the age of the child, for example, 10 years of age or 10 and a half years of age, a girl, and the mother worried about menses is soon because the mother noticed all the signs of puberty is around, and she's afraid the child have menses because she said my child or my girl is not ready psychologically, even for hygiene reason of view, to have her menses. For me, I'll consider it an indication to start generation agonist because we are not only treating central precocious puberty because of final adult height, we are considered also for behavioral and psychological issue. For me, I'll consider it one of the indication to start GnRH agonist. What's your view, Dr. Muhammad?
Thank you very much, Prof. Abdelmain. I think the other components of the pediatrics that we shouldn't forget, patients with special needs. For example, patients with Down syndrome, cerebral palsy, Prader-Willi, all of these syndromatic patients, they might not be ready neither from the physiological nor the emotional and the self preparations for the pubertal changes. So I think in these patients, it's indicated for certain time with the agreement of the parents based on case by case. Case by case, it depends.
In those patients, we need to monitor body mass index for bone mineral or not.
Well, you mean as a complications of the
Yes,
treatment?
if we use more than 6 months for this patient whom bedridden.
If you did the prophylactic management by supplying these patients with enough vitamin D, either prophylactic or therapeutic if the patient is deficient, with the enough calcium supplements, either from the dairy products or if the patient is having any sort of allergy or not able to take the calcium, you have to supply these patients by calcium. By doing this, you will prevent much of the complications of osteoporosis in these patients.
How if we can enable to give this patient, especially with comorbidities like cerebral palsy, they have swallowing difficulty and recurrent hospitalization, we can make sure of calcium and vitamin D intake on those patients.
Well, this is again, you have a lot of patients having special needs. They are special situations, so they have special needs. Whether these patients either receive it from enteral or parenteral, you have to supply these patients with the enough and appropriate doses of medications to prevent them. The GnRH analog is indicated in such patients if they are really the patient or the parents, because they are the one taking care of this patient, are not ready yet for the changes in these patients.
How about if this patient present with precocious puberty and they are already have comorbidity and they are bedridden, and we know the major concern or goal for GnRH agonist to promote final adult height. While those patients' height is not important that much as the healthy child. is we concerned to give GnRH with and expose the patient to complication and final predicted adult height is not important for him?
Yes, of course. Your answer, your question is clear and up to the point. Means uh, we have different targets when we manage the precocious puberty. Are you treating the final height? Are you treating the emotional? Are you treating the physical body or the patient herself having these physiological changes? If the height is not a major goal for you, no need to go for these medications unless the patient is suffering, because these patients, the problem is they will require more of the need, much more than that they have for their initial problems. For example, seizure, giving them medications, NG feeds, etc. So you are making it more complicated.
Just a quick answer of doing bone mineral density in children receiving gene rich agonist. If it's is no other associated problem lead to osteoporosis. For example, as you mentioned, a child with cerebral palsy and central precocious puberty. So cerebral palsy is one of the causes of immobilization, and immobilization is one of the causes of osteoporosis. If the child is having immobilization in addition to precocious puberty, yes, it is indicated in addition to supplement, the calcium vitamin D is indicated to screen for osteoporosis or a child for whatever reason of osteoporosis, malabsorption, uh, immobilization, steroid medication, whatever the reason of causes lead to osteoporosis, and this child has to be treated with GnRH agonist. So we have a combination of two GnRH agonists and another medical condition. We have to do bone mineral density to be sure that no osteoporosis. But a GnRH agonist alone is not a steroid. It's not like somebody steroid. After 6 months, you do screening for bone mineral density. There is a risk, but it's not as high as children treating with steroids. So with supplement, inshallah, enough to prevent the osteoporosis.
شكرا دكتور بروف المعين and محمد دكتور محمد. I agree totally for the other indications, i.e., the emotional and the behavioral. A lot of patients in my clinic, they have autistic child, and they are totally with other problems, and the parents, the mother, the father, they are totally come in the clinic, they are shocked. So after treatment by 6 months or whatever, they came and they said, يعني, alhamdulillah, thanks, we are at least we are in good shape. So yes, there is other indications to go for specific. So it's individualized patient approach.
Thank you very much. We are, as a physician, we have to look for psychosocial issues. Yani not only our practice is just for height, final adult height, whether the child short or not. For the family, sometimes psychosocial issues is very important, especially for the females, especially menstruation. Menstruation is not an easy thing. And when the mother, even the child is not autistic, even the child is normal, but still 9 years of age. Sometimes you have a child 9 years of age with immaturity. The mother thinks that the child still is not having the good mind or maturity to deal with such issues, especially the hygiene. And for this reason also we have to consider we are not just 1 + 1 = 2. For example, age of child 10 years should have menstruation by 11. The normal age 11 to 12 or 13. She's now 10. They said, okay, it's 10 near to 11. Let's have her menstruation. Depends on the mother, depends on the family. Some of them they accept child to have 10 years of age to menses. Other families, even normal, not autistic, not cerebral palsy, doesn't accept their child to have period by 10 years. So we have to consider familial concern. Family concern is also part of our job. We cannot ignore concerns of the mother or the family. Number four, what is the cutoff level of basal and stimulated LH level for central precocious puberty?
I think this point has been mentioned clearly in the theoretical part by the Prof. Mahin, and then on the first case, that if the level is above 6.6 and above of the LH and FSH 4.2 and above, this is diagnostic. This is central precocious puberty as a baseline. The stimulated, some references 4 to 5, so anything above 4 is diagnostic also of the central precocious puberty. طبعا LH.
I think, yes, agree 100%, but I think for the stimulated, most of the center said above 5. Above 5. So basal above 0.6, stimulated above 5. Number 5 questions. And there is any other question? Okay. From the audience, any question? Okay, there's another one now come. Does 3 monthly preparation of triptorelin depot on the weight of the patient? Yes. Depend on the weight, yes, we mentioned it. We mentioned that if the child weight more than 30 kilogram, full dose of 11.25 milligram. If the weight of the child between 20 and 30 kilogram, the child should receive 2/3 of the injection. If the weight of the child less than 20 kilogram, the patient should, or the child should receive half of the dose of 11.25 milligram. This is, we mention it as Saudi FDA recommendation on the pamphlet of the medication. If there is a question, another question. Okay, for how long shall I use the medication? Dr. Ahmed.
It was mentioned by both. I think each case depends on the individual indication. So what was your indication? Was it the height, final height? Was it the emotional? Was it the progression of the disease itself? So based on your target, you have to tailor the duration of the medication. So it's not fixed for everyone.
This is medicine. Medicine, now in every treatment of any child, they said individualized treatment. So there is no general rule for everyone. And it depends on many factors, on the predicted final adult height of the child, on the psychosocial aspect of the family, and on the underlying cause of precocious puberty. So myself, depends on many factors to decide for how long. There is no cut-off age, like, for example, age of 12 and you have to stop. Sometimes you have to stop by age of 12, sometimes by age of 11, sometimes by 13. It depends what is the underlying cause, what will be the final adult height, and what will be the psychosocial aspect of the family. Any further questions? Okay. In mentally retarded patient with no precocious puberty, for how long we can continue the treatment to suppress menses in female and the sexual drive in male? This is another good question, maybe related to the previous answer of the previous question, that, for example, you have a mentally retarded child, age of 15, and he has a lot of sexual drive, and his sexuality might affect his sister at home, or the neighbor or his aunt or his cousin. Not because he's 15 or 16, we said we have to stop. It depends how bad is the sexuality of the child. Is he aggressive sexually, has aggressive sexual drive or not? And the same thing for the female. If the mother is so worried about her menses, her hygiene, so it depends on family. Each family different than the other. That's why there is no general rule by age. For example, like this, if you have a mental retarded child, by this age we should not continue on GnRH agonist, or if you have a 16-year-old child, male with high sexuality drive, you have to stop. There is no depends from family to another family. And by the way, there is another cheaper medication called Brovira Depot, much cheaper than GnRH agonist. So if your concern is not final adult height and mentally uh, uh, retarded children, you could use the cheap preparation, which is medroxyprogesterone depot preparation, which is called Provera, every 3 months. That is much, much cheaper to suppress the puberty, and you don't need to have expensive medication because GnRH agonist has the advantage over Provera in improving final adult height. But if you are not concerned in the final adult height, you could use the cheaper preparation, which is 17 medroxyprogesterone Provera every 3 months. What is the next step after GnRH agonist treatment for a special need? For how long we can use GnRH? This is the same answer of the previous question. Okay, really, I was so impressed with the interaction of the doctors attending this seminar or this campaign from local audience as well as from online. I feel now happy that the people with us were interacting, were having an intelligent source of communication and thinking. And I hope, I pray Allah that we did some of transforming some of the knowledge to our colleagues that will help in their daily practice of dealing with children with precocious puberty central, whether diagnostic and therapeutic. And by the end, I would like to thank my dear friend and colleague, Dr. Muhammad Al-Gahtani. And inshallah, very soon we'll not tell Dr. Muhammad, we'll say Professor Muhammad. Inshallah, he's in the promotion process of his professor. And we'd like to thank our dear colleagues from Epson, namely Dr. Munira, Nada, Rihad, Amr, Dr. Amr. They are very, very keen to have this campaign to be continued. And inshallah, in 2024, we are going to have this campaign in different cities of the country. So far, we had one in Riyadh. This is second one in Al-Khobar. And inshallah, 2024 will have many cities included. Without their sponsorship, without their participation, we could not deliver such information to everyone. Until inshallah to see you again in another campaign. نستودعكم الله دينكم وأماناتكم وخواتيم عملكم وجمعة مباركة ولا تنسونا من صالح دعائكم.